Good. Okay. Good afternoon.
Buenas tardes.
Good morning. Sorry. In the meantime, those who are and how you prefer to view slides and participants. Okay, we'll give a few more minutes, usually 5 minutes, to see if more people join, and then we'll start. Thank you very much. Hello, everyone, again. We're gonna start. My name, again, is Maristela Monteiro. I'm the Senior Advisor on Alcohol at the Pan American Health Organization, Department of Non-Communicable Diseases and Mental Health. And I'll be moderating this session today. It is my great pleasure to be hosting two very well-known experts in the area of alcohol epidemiology. and policy analysis, and also investigators who are now part of a new collaborating center that was nominated this year, the Center for CISUR, I'm sorry that I forgot, the International Center for Alcohol Research, Alcohol and Drug Research in British Columbia, Canada. And the topic today is about using the international model of alcohol harms and policies in countries of our region. We're gonna have two speakers, Adam Shirk, that will provide an idea of the model and the tool that they have developed, followed by Tim Stockwell, who will provide a concrete example of how the tool was used in Canada, but also it has already been used in several other countries. Some of you may know that we are offering also training to individual countries on the use of the tool with their own data sets, all the data that they could provide and help you through analysis and inputs into the tool and how to use the data afterwards. So if countries are interested, they can contact us. We're going to begin with a few countries, but we'll be open to any country who decides to use the tool to provide that assistance. So without delay, I pass the floor to Adam Shirk, please.
Thank you, Maristella. I'll just share the presentation. And thank you for having me today. I know both Tim, my colleague, and I are here and today we'll talk about estimating alcohol-caused harm and modeling alcohol policy scenarios in PAHO member states. Both Tim and I work at the University of Victoria's Canadian Institute for Substance Use Research, and we're both presenting today from Victoria, British Columbia, Canada. An overview of the presentation. So first I'll give an overview of Intermap, the International Model of Alcohol Harms and Policies, the model itself, what it can be used for, and then kind of a meaty part in the middle of the presentation is some examples of use. So that'll give us more of a flavor of what we can use Intermap for, how it might be able to help your alcohol research team kind of forward the research in that regard. So we'll look at 3 examples in different countries in New Zealand, Finland, and Canada. And then as Maristella was saying, PAHO is going to be offering Intermap workshops. So at the end of the presentation, I'll talk a little bit more, just a few slides about a bit more technical stuff, what would be needed for participants to participate in those workshops. So you have more of an idea, but that part will be short. Intermap's statement of purpose. So I wanted to start with this, the purpose when Tim and I and others kind of thought about developing this model was to help standardize international methods for estimating alcohol harms, for estimating alcohol's burden of disease. Because this is done differentially in different countries, it's done differentially by different organizations. And so Intermap provides a framework that doesn't completely standardize, but works towards standardization of these methods so that estimates of alcohol-caused harm across countries are more comparable to each other. And this is particularly important within regions, within the Americas region, for example, when we're close to each other. So we want to be able to compare the numbers more effectively. Another main driver behind us building this model and making it accessible was to make these methods in alcohol epidemiology more accessible to more teams. So some countries have lots of resources, some have fewer. And by automating part of the research process, you can get more work out the door. You can ask more questions of the data. And then last, we wanted to provide a collaborative platform where all alcohol researchers can contribute to improving the model. So we've had some users give us input, and we've worked that into versions of the model as it's evolved. So those three things together were what kind of led us to build the model in the first place. Well, first, it's important to note that it's open access. So any research team can use this model. It's freely available online. You'll see the link at the bottom there at intermap.csir.ca. So it's the model itself consists of the methodology behind it and this software that's available on the website. And what it does is it can assist alcohol research teams, teams that are working in either alcohol epidemiology or alcohol policy, with finding alcohol's burden of disease. And then further, like we'll talk about in the examples, it helps teams hypothesize what might happen in alcohol policy modeling scenarios if a particular alcohol policy was implemented, for example. The teams provide, so importantly, Intermap, it's not a panacea. So the teams that are using it still need to be able to provide some basic level of data about their region to tailor this model to their region. So the model will require things like region-specific drinking data, alcohol per capita, something about drinking patterns, and some minimum level of health data. I'll talk a little bit more about that at the end in a bit more detail. A few examples of questions that Intermap can answer. So what would we ask of the model, or what would we use the model to assist us in answering? This is something that we've done a lot. How many deaths or how many disability adjusted life years excuse me, were caused by alcohol in a given period of time, say in 2020? And then further on the policy side, it can be any policy, of course, but here I've chosen a very effective one. If an alcohol minimum unit price policy was implemented, how many lives or how many dollars would be saved? So this is an important piece when talking to policymakers about potentially putting policies in place. What are we going to get out of it? How many lives will be prevented? How many hospital stays will be prevented? And what does that mean for the bottom line? It's a good lever to have when talking with policymakers. So here's a couple of examples of the type of research that can be done. This is part of the, we published 3 articles that kind of defined the model. Originally in the Journal of Studies on Alcohol and Drugs. The first in the top left, we defined the model and then we estimated alcohol-caused mortality in Canada. And then in the bottom right, this is one where we had a look at what would happen if a minimum unit price was implemented in the Canadian province of Quebec. What would the health impact be of implementing that minimum unit price? And that's been effective when talking with policymakers in that province. Who is Intermap intended for? So Intermap is intended for largely people already working in the field of alcohol research, alcohol epidemiology, or alcohol policy, looking to either estimate harms in their region or to think about what would happen if an alcohol policy was implemented. Helps to calculate alcohol's burden of disease. And then that second piece is about policy. So it can be people working in alcohol policy, policymakers, considering implementing alcohol policy changes. How would those changes impact population health? And we can ask questions along those lines. And then it's good to reiterate, so the region can be and often is a country happening at a national scale, but they can be subnational units as well. So in Canada, we've done a lot of work in our provinces. We've done work in US states, even large cities. As long as the data exists, you can look at what would happen if cities were to implement alcohol policies as well, or health regions. So it is often at the nation level, but it doesn't have to be. It depends where you're working, and also in some regard what data is available. An overview and a little bit of background of where Intermap came from. So it was developed, a piece of it was developed as part of my PhD dissertation a few years ago. But then Tim Stockwell and I also worked with authors of the 2018 WHO Global Status Report on Alcohol and Health. So Jürgen Rehm and Kevin Shield, who many of you probably know, they're also part of the PAHO Collaborating Center. They were co-authors and still are co-authors of Intermap, critical to developing the model in the first place. We first released it, the first version was released at the end of 2017, and it provided this framework for countries to use for calculating alcohol attributable fractions, which helps to estimate alcohol's burden of disease in a particular region. But now we're up to, through different releases, we've got up to just last year, version 3. So this is that back and forth I was talking about. We've developed a user base. There's not that many people working in alcohol research worldwide, but many of them at least have had a look at Intermap. They've sent us comments and improvements, and we've tried to build those into the models over time. So we're up to version 3. And importantly, now it's important to get across, so you don't need any software to run Intermap. It's entirely web-based. So you go to the website, which was up before, and then you upload your data into the tool itself. You don't need any program on your computer to do that. It's just internet-based. And Intermap, we'll talk about this a bit in the examples section, has been used in these countries below, and we'll talk about 3 of those countries in particular. So to get an idea of what Intermap is used for, we have these 3 examples of use. So I'll start off with New Zealand. This is a project that I'm working on right now. I'm working with a team out of the University of Otago in New Zealand. And it had been many years since New Zealand had estimated the alcohol-caused burden of disease in their country. So they wanted us to build what's called a national alcohol harms monitoring system. How much harm is alcohol causing? Deaths, hospital stays, injuries, this type of thing. How much is alcohol contributing to the total burden of disease in New Zealand? And this is interesting for the first time. So the bid was put out by New Zealand's Health Promotion Agency, and their request for proposal actually required the winning team to use Intermap, which was a good kind of testament towards the model itself. So I got roped in with the team, and we've been working on that for a while now. So Intermap provides the framework, but the data that goes into the model, that's all New Zealand specific. So it's data on drinking levels, on drinking patterns, and then data, New Zealand specific data on injuries and hospital admissions, mortalities, and things like that. So Intermap assists by composing those different pieces of information into the alcohol-caused burden of disease. And that's the piece that Intermap is very effective at kind of reducing the workload for teams. Because when we used to do this before Intermap, it would take some time to do that step of the project, and now it's all automated by this online application. A second piece that we did, and this is more on the policy modeling aspect of it, and I'll pass it over in a slide here to my colleague, Tim Stockwell. We did a project in Finland, an alcohol policy modeling project, where we wanted to estimate the potential health impact in many different areas in terms of potentially changing alcohol policy. So as a study of policy change, this affected different alcohol policy levers that Tim will talk specifically about. But it was hypothetically, if Finland's retail monopoly was removed, their public government-run alcohol retail monopoly. And again, we get that Finnish-specific data. So the Intermap really tailors the results that come out of it to the country in question. And as I said, it composes this information into that alcohol cost burden. And we can estimate the health impact of potential different policy changes. That's a picture of our report that came out of it. And at this point, I'm going to pass it over to my colleague, Tim Stockwell, and he was the principal investigator of this study. Oh, you're muted, Tim.
I beg your pardon. I thought I'd just unmuted. Good afternoon to some of you. Good morning to the others. Thank you to Maristella and the team at PAHO for the invitation to do this webinar. Adam's too modest, perhaps, to mention, but the Euro WHO office has also run some training workshops to promote Intermap. And I just want to say there's an awful lot of work that Adam put into creating this beast that has proved so useful to so many people. And it's really wonderful to see its popularity and application become so wide. And particularly, it used to be kind of a black box that people didn't really understand how these global burden of disease estimates that probably most of us are familiar with, how many lives are lost or years of life are lost from, whether it's drugs or alcohol or tobacco. And Adam, by creating the documentation, has made it crystal clear. There's nothing hidden. Anyway, so it's great to see the application. Now, I'm going to try and show you, like from the other end, I feel like I'm a consumer of Intermap, and so maybe I'll be looking at it like some of you might be. What can we use this for? What would be the end product that would come up with it? So I'm going to show you some rather specific examples of studies, of the policy studies that could not have been done or would have taken a lot longer and huge expense had we not had Intermap. So that this is the Finnish study. We were contracted by Alko. This is maybe a strange concept for people in the Americas, but it's a government alcohol monopoly that controls, owns the distribution of alcohol and owns a considerable number of liquor stores. Not all of them. I mean, supermarkets can sell alcohol below a certain strength, and from memory, it's 5.7% strength is the cutoff. Below that, you can buy in the supermarket. Above that, you have to go to an Alko store. So we were asked, if you could, I'm going to put my finger up each time that Adam's going to advance the slides. Hope this works. There's my finger going up to the next part. Yeah, the first aim was we're just going to do an estimate of what were the harms and costs from alcohol in 2018. The second aim was to look at how these would change under two alternative policy scenarios. The first of which was that the current policies were actually strengthened. So Sweden also has a government alcohol monopoly, but it's tougher. They have fewer stores, shorter hours, higher prices, and a range of other protections against alcohol-related harm. The second one, would we entirely get rid of Alko? And I should say, you might be feeling, well, this doesn't apply to me in my country. The government's never going to be in the business of distributing and selling alcohol. But this is just an example. Any policy, whether it's a tax increase, minimum unit price being introduced, a reduction in outlet density, so long as you can quantify the change in price or availability, we can estimate the change in consumption. We can then estimate the impacts on harm. If you have the next slide. So first, some specific examples. In this Finnish study, for each policy scenario, we tried to define what were the relevant policies, and based on comprehensive reviews, and this is not controversial, there's fairly good agreement. Well, there's very strong agreement in the field that it's price and availability. We've quantified those in those different ways: the density of stores, the hours of trading, how many days of trading, minimum price, average price. And then we estimated the impact of the changes in policies. We needed expert input to define the present policies and then how they would change in the different policy scenarios. We then used, wherever available, systematic reviews to estimate the impact on alcohol consumption. And we did that both for recorded and unrecorded consumption. So what would be the change in consumption? And the next one would be the change in harm. And this is where Intermap comes in. And so Intermap should appear in red letters. And the first three items there, deaths, hospitalizations, and disabilities, we could not have done these Finnish specific estimates without Intermap. The crime part was done separately. And then we also used standard cost of illness methods to apply dollars to those harms and estimate what they would cost and what the changes in those would be. So I got some, next slide. Thank you. So this is just to illustrate what it comes out at the end. I showed these slides to the board of management of Alko, to a whole lot of stakeholders in Helsinki, Finland, because there's a lot of political interest, and it's a topic in general elections, whether to keep the monopoly and what to do about alcohol policy, because there have been quite serious problems with alcohol in Finland in the past. So if they were to, the bottom line is, with consumption, if the Swedish policies were introduced, we estimated the impact on consumption to be a reduction of consumption by 16%. And how that would then impact harms is where Intermap comes in. And so we have a 21% reduction in deaths. We've got specific numbers for Finland. I forget the exact population of Finland. I think it's about 5 million. Can you remember, Adam? Nod? I think that's about right. So that you give the scale, but there's the percentage change in hospitalizations, long-term disability cases and crimes. But then the other scenario were alcohol to be abolished, removed. The impact of consumption would be an increase. This was estimated of 9%. And here are the corresponding increases in deaths and hospitalizations and disabilities and so forth. And it's the contrast between the two. And that's why we called this study, Finnish alcohol policy at the crossroads. This is what happens if you strengthen things. This is what happens if you give it all away. And most countries, of course, have given such controls away, but this is a very acute example. We'll now go to the costs very quickly, just to show how the corresponding costs looked. This is the Swedish scenario. Finland strengthens policies and nearly 400 million euros saved in costs. And in the other scenario, nearly 300 million extra costs if the taps were to be turned on full and no restrictions, and alcohol would be sold. All alcohol would be sold in all the supermarkets and grocery stores. So that's just hopefully gives you a very specific set of examples. I'm now going to go into, well, let's just have the final little conclusions from this, which was just to show this is the total estimate of the, first of all, we used Intermap to estimate the total impact of alcohol in the year in questions of 4,000 deaths and 46,000 hospital admissions, cost of $1.6 billion. Then how that would change, the savings, the reductions in costs and savings of life and preventing illness and injury. And then the other way round, how things would be made worse if this government monopoly was removed. the costs increased by 17%. And finally, the conclusion overall is this illustrates how the fewer restrictions on the sale of alcohol, while this creates an efficient marketplace, and this is something economists and many business people want, they want an efficient market as efficient as possible to the population. Well, this sort of exercise estimates the impact of that on the population and the health of the population, and shows how that results in greater harm. So the next example, which I will scoot through, is it's a cost study, an economic costs of substance use study, which we did in partnership with the Canadian Centre on Substance Use and Addiction. And we'll just show you some specific. Next slide. Our agency, Adam and I both work, Canadian Institute for Substance Use Research. So we're a multidisciplinary group based at a university. We've been around for nearly 20 years. And I think just what I want to stress here is that we are about independent research. We do not take funds from any industry group, whether they make cannabis, tobacco, alcohol, pharmaceuticals. And our aim is not to profit from the research we do. We get our funding from whether it's government contracts or peer-reviewed research funds. Those are our two main funding sources. But our aim is to inform public debate and provide as many people out there, whether it's in Canada or the world, with tools to do better research to inform improved alcohol and public health policy. Our collaborators at CCSA are the main national agency that addresses policy and advises treatment and prevention practice for Canadians. Move on to the next slide. And the funding for this work was from Health Canada. That's the Ministry of Health, the Federal Ministry of Health here. So the background to the study, the main features, we were funded to come up with new economic costs of substance use for Canada. They were last done by Jürgen Rehm around about 2006 was the last report, but the data were for, I think, 2002. So almost 20 years old. We now update this. This is an ongoing project. Thanks to Intermap, we can generate and other. It's not just Intermap that produced this, but we couldn't have done the alcohol bit without Intermap. We do this every year, and there's an interactive website that we will show you that you can investigate all the results and download tables and figures and so forth. So the 8 substances you can see on the screen there, legal, of course, cannabis is legal now in Canada, and illicit substances, prescribed drugs as well, and the 8 categories are on the screen. Then the types of cost we looked at and harm were in the area of healthcare, the workplace, lost productivity, criminal justice, and other direct costs. There was, I won't go into the things like fire damage. There was a whole research costs. There's a whole lot of small things bundled together. Next slide. And we use the attributable fraction methodology, and I don't think I can do this justice. There's a beautiful formula, and you should hear Adam talk. You'll hear Adam talk about this if you attend the workshop and how to do this stuff. Basically, what you need to know, what Intermap uses, is estimates of the risk of getting different diseases or injuries according to how much you drink. So these relative risk estimates. But then you also need to know how many people in a country are drinking at these levels, the exposure to the risk from alcohol. And then if you also have data on how many cases there are of illnesses and injuries that are either fully or partially caused by alcohol, then there's a formula that combines those, and you can come up with this fraction. So what percentage is all it means. So what percentage of car crashes are caused by alcohol? What percentage of cases of liver cirrhosis are caused by alcohol, and so on. And so Intermap automates that complicated stuff if you input the key information. Next slide. I'm not going to boast about the strength. We're very proud of our study, but look, we used the best available data. It was really comprehensive. We used methods approved by WHO. We had access to incredible data sets and a fantastic advisory committee of leading experts. So I'm going to show you some results, which hopefully will whet your appetite to apply, to try and do this kind of study for alcohol in your country. So the first output. So one of the big take-homes from our last report, which is produced in 2020, was that most of the costs are from the main traditional legal drugs, alcohol and tobacco. And you can see the comparison. Now, these are the total economic costs. The total costs for all substances were $46 billion in 2017, which overall was $1,258, these Canadian dollars, for every man, woman, and child in Canada. And 63% of those costs were attributable to alcohol and tobacco. Next slide, please. The biggest proportion of those costs across all the substances was lost productivity. So this stemmed from absenteeism, disability, years of life, productive years of life lost, people dying before the age of 65. And so we valued the impact of that lost productivity and healthcare. So between them, they accounted for 70% of the costs, but criminal justice was of costs for 20%. Next slide. And this shows how we provided estimates for different jurisdictions in Canada. It's not all of the jurisdictions of the Canada-wide one, but you see at the bottom, it was able to identify that the northern areas of Canada have some of the heaviest drinking in the country, and the impacts are staggering. They are way ahead of other areas of, it seems to apply across the whole of the north of Canada. Things are far worse. But so we could individualize the estimates to different regions, and the policymakers, and we provided tailor-made sort of snapshots for each region for the policymakers in those regions. Next slide. Nearly there. So alcohol costs the most. This is the same slide as before, the total costs divided by substance, but just highlight how, it costs more than tobacco. It actually alcohol costs more than all the other drugs and tobacco put together. So many people would assume opioids cause more harm than alcohol, particularly as we have, well, much of the Americas have an opioid crisis. But at the time of our work, alcohol was still far and away more costly than opioids and even tobacco. So let's go to the next. And so let's just highlight, we can make this estimate for 2017. All of these numbers, of course, increased with population, and actually we've had more consumption as a result of the COVID restrictions. But in 2017, 18,300 deaths. The population of Canada, Adam, I'm thinking is roughly 36 million, to give you a sense of what these numbers mean. It's probably slightly higher. Over 100,000 hospital admissions, and 6.7 billion in economic loss of production. 20% of violent crimes in Canada were estimated to be alcohol attributable, and that's a very conservative estimate. Next slide. Now, this is just drilling down to some specifics. Tobacco, this little slide shows the number of deaths estimated in each of the 3 years that we looked at by substance type. So the brown bars are tobacco. And so there was, is that correct? Okay, 74,800 substance use attributable deaths. Yes, that's about 48,000 of those were caused by tobacco, 18,000 from alcohol, and the rest roughly 19,000 from other substances. But if you look at productive years of life loss, and I'm going to illustrate that in the next slide, we have alcohol leads the way with 114,000. I prefer the term productive years of life lost. Adam prefers the term PIPL, which I think he invented, but either will do the job. But it's the number of years of life before 65. So it's about 100,000 for opioids, 114,000 for alcohol, and 68,000 from tobacco in Canada. And this figure just lines them up. But look at the trend for the opioids. It looks like it should, and it may already have, overtaken alcohol in Canada. So that's one of the advantages of an ongoing series of estimates and a study, like we call it CSUCH, the Canadian Substance Use Costs and Harms Study. And I think the next slide will show a website. Yes. Tools to make these estimates and results as available as possible. We have all manner of ways in which people can find them, explore them, download, and get tailor-made. So if somebody in Saskatchewan wants to know about what is happening, what are the impacts of cocaine for a particular age group, they can go into our data visualization tool, and you could, if you happen to be interested in Saskatchewan or Quebec or the whole of Canada, and it produces figures and data tables for the cost estimates by year, by substance type, and by type of harm. So that's, anyway, we're kind of excited to share that with you, and I hope that gives you a taste of the amazing potential that Intermap has unlocked. And my last thing I'd say is, this used to take months or even years to come up with these estimates, and now we can get them with a click of a button. You can get instant results once the work has been done and the data are input there. This is the kind of thing you can do with it, and hopefully that moves policy on, and we improve public health and safety responses to substance use problems, and particularly alcohol in this case. Thank you.
So I'll just say a little bit more at the end, which is a bit more specifics about Intermap. Oh, sorry. Yeah, thanks so much for that really interesting overview, Tim, and thanks for your kind, probably too kind words about Intermap at the beginning. I really appreciate it. Just to talk about that cost study, the Canada's National Cost of Substance Use Study a bit. I know this presentation today is about Intermap, the model, but if other teams are interested about this health economics piece, to the best of my knowledge, this Canadian study that Tim is a co-PI on is really leading edge. Nobody else is doing that type of work and updating it every year, as far as I know, so if others are interested in the health economics, the cost of substance use, Tim and I and our partners at CCSA, which Tim mentioned for the project, are happy to be in touch with you about that topic as well. It's something that we're both interested in. At the end here, I just wanted to talk a little bit about Intermap in slightly more detail with an eye towards these workshops. So kind of thinking about, is it something that I would want to participate in? Would my region be able to participate in it? So that the type of data that we need to be able to feed into Intermap to be able to produce the useful estimates on the other side. We need to be able to calculate some regional drinking information. Typically, this is from surveys of alcohol use, and then, if possible, number two there, an estimate of per capita alcohol use. This can be from surveys, but it's better if it's from sales, the sales data. We're kind of spoiled in countries that have retail monopolies because the government tracks this quite well. And so we tend to get really strong estimates of alcohol per capita. This is not the case, in all countries. So we can use surveys, and then we can adjust them upwards to take into account the known underreporting in surveys. That we need that prevalence of alcohol use, and something like prevalence of binge occasions, heavy drinking occasions. And then typically we feed an estimate for people that used to be drinkers but aren't anymore. And then it helps, this isn't totally necessary, but it helps to improve the estimates that will come out if we have access to health data of some sort in the region in particular. So this can be mortality data, you know, the vital stats mortality data. It can be something on the morbidity side, like hospital stays or emergency department visits. We've both of those. We've used both of those. Injuries, record of injuries. So that type of data helps to compose it into something that we can really chew on and get some interesting results out the other end. Yeah, so Tim talked about this. So I'm just going to skip over this slide because I want to provide time for questions. We'd love to take questions at the end. And Tim was talking about that formula. So for those of us that are kind of, you know, geeky on the formula side, I'm happy to just show it here. And we use the bottom one, originally developed by Jürgen Riem and some of his colleagues, this continuous formulation of the population attributable fraction. That's what Intermap uses to drive its estimations of the alcohol attributable fractions. And we thank you very much. Ask a question now, or Tim or I are happy to be contacted, you know, about any questions that you might have. Thanks for the opportunity.
Thank you very much. It was very clear and helpful. And I have here 3 questions. We'll start with those. In Mexico, if you know of any study like the ones that Tim reported, or if you worked with them, and if their interest is in fatalities from road injuries, if that could be done from alcohol, and the cost of that. And the other comment it was asking if the question, if hospital visits are the same as hospital discharges.
Sure, I can start. Maybe Tim can add something at the end. I'm not aware of any studies that do that in Mexico, but Tim might have a better handle on that literature. I'll let him speak. For collisions, for traffic accidents, yes, Intermap can help with that. So the way that burden of disease is done for some acute conditions like collisions and injuries is a little bit chunky. It's a little bit, it isn't ideal, but it is what it is. So we can produce estimates of acute injuries and collisions using Intermap. It's surely better than nothing. The best estimates are kind of region specific estimates that, like, for example, what we do what we do in Canada for our national alcohol harms monitoring system is we use Intermap to calculate all the other attributable fractions, but we feed in motor vehicle collision attributable fractions from these quite detailed reports that we get from provincial agencies that actually test the blood of people that have passed away in collision fatalities and things like this. That gives us a better measure. The attributable fraction that comes out of Intermap is not as refined as that. So it's a piece of advice that Intermap gives is to have region specific acute AFs where possible. But Intermap will provide kind of a basic level of estimation towards that. Oh, there's a third part of the question that I've forgotten because I
hospital discharges versus hospital stays.
Yes. Yeah, same thing, you know, yeah. So admissions and discharges, in almost all cases, that's the same. Someone could die in hospital, so you have to take that into account. In Canada, we call those, discharges. So yeah, I would say those are the same.
All right. I open the floor if anyone wants to raise their hands and ask any question. Let me see here. What I would like to say is there are two ways that people can use the tool. They're free to go to the site and try themselves. There is guidance on how to do it there, as I understand, but the tool is only in English. But what PAHO is offering for member states is that if the government, Ministry of Health, has an interest in using country data and use the tool, that PAHO can assist by providing interpretation for a training workshop and then follow-up consultations with the team in Canada. And the way to ask the country office to submit a request for technical cooperation, and we'll start a conversation. So the Ministry of Health or a department contacts PAHO and say, we want to do this, and who we should contact, and they come in contact with me with CISUR and the team, and we organize dates, times, etc. If another question, if she understood well, is there a possibility to apply the tool for other substances? Oh, and there was, sorry, another one. Thanks for the great presentation. How often the data is updated at CISUR? The information right for all Canadian process are for 2017. Alcohol policies have changed quite a bit in some province, or is there any study for recent years?
Shall I just quickly respond to that? Thank you. We're actually working away, this team of 12 of us, some of the personnel change, but we're just working on an update to 2020, and we hope to have that ready next spring. So sometimes it's been an annual process. This is going to be more like a 3-year lag, but when we're finished, there'll be yearly estimates. And there's a parallel project known as CAPE, or the Canadian Alcohol Policy Evaluation, which documents policy implementation in Canadian jurisdictions. So we have these two streams of ongoing analysis, and we're just in the process of updating the Canadian policy assessments in jurisdictions and looking at how they connect.
Yeah, and then I would just add to that, like the recency of the data is unrelated to Intermap. Intermap is a methodological framework and software, but then it's dependent on when we can get the data to feed into it. So that's not a restriction of Intermap. It depends on each kind of region specific, the data requirements in each specific region. The other question was about whether or not it can be used for other substances. No, so Intermap is just about alcohol. It's about automating and helping teams with the calculation of alcohol attributable fractions. Luckily, the calculating those attributable fractions for other substances is much easier because one of the pieces that is needed is the relative risk information, the dose response relationship between the use of the substance and the risk, which typically escalates. And that is rare. For no other substance is that continuous. So it's this kind of continuity piece that makes the estimation more difficult, which lends alcohol specifically to being able to be automated in this way where it would save a lot of time. For the other substances, like when we do this for the National Cost of Substance Use study in Canada, it's much quicker to estimate the harms caused by other substances because of this. So, Tim.
Yeah, I just want to add that it's occurred to me recently how important it is to go the extra mile for alcohol, because about 90%, if you think of the deaths from attributable to alcohol, 90% of them are partially attributable, so they're not like cancers. I think the one estimate is about 15% of breast cancer cases are alcohol attributable. That'll vary in different countries, but so these deaths, these tragic deaths, don't come with an alcohol label, and whereas with opioid deaths, it's usually very clear. There's a coroner's inquest, and we know, and the evidence is perhaps to hand where the person has died from an overdose. So it's really, really important. Is why we need the extra this kind of sophisticated tool. And of course, we have much more data on our favorite legal drug to have those exact dose response risk estimates.
Thank you. And which ones of the policies offer the best results to reduce the cost of alcohol?
You're pausing. It sounds like you want me to answer that, Adam.
Yeah, I think Tim will lead us out on that.
Oh, well, I'll give it a go. Well, look, we try to quantify this. And if you get a group of people who work in the field, in fact, if you were to study all the comprehensive reviews, there's a fairly consistent set of conclusions about which policies have the most impact. And at the top is always pricing, and whether that's influenced through taxation or the new viral craze almost for minimum pricing, which I think is a very good, if you're going to have a virus, that's a very good one to have, because it seems to be so effective, setting a floor price on alcohol. Incidentally, a very good policy in many now, if we want to build back better, if hopefully we are going to emerge from the pandemic, it is a means whereby some governments can make more money. They need money. The industries will not suffer as much as with a big increase in excise tax. However, public health benefits from tax increases as well. The other ones would be availability. So the hours of trading, the density of liquor outlets, and the extent to which impaired driving, we know for many years there are effective ways that's a very specific type of harm. Advertising and marketing is another best buy. I should really let Maristella answer this, because WHO has 5 best buys, and with safer. Actually, I'm going to shut up and let Maristella fill in the gaps.
There are 3 best buys and 2 very good buys, and the package of 5 very good interventions overall has been named safer, but includes taxation, marketing control, reduce availability control, brief interventions, and drink driving countermeasures. So yes, and pricing, you're right, through taxation is the most cost effective. And the more you combine of policies, the better the result as well. I have here 2 questions from the same person, Gregor Swern. If one has input data on alcohol use, frequency, and quantity, binge drinking and former drinkers, why does one need per capita consumption? And the dose response relative risks are crucial, as well as the number of diseases that are being considered. Can these variables be modified and adapted to different regions within the model?
Okay, the first question about alcohol per capita. So it's largely because of this known issue of underreporting and self-reported surveys. So when we look at the amount of total alcohol sales, let's use Canada for example, all alcohol sales that are captured when we ask people how much they drink, that percentage is extremely small. It's about 30 or 35%. Right, so if we ask people how much they drink, they underestimate by a factor of about 3. So by using sales, it basically pegs an amount, a quantity, which is well known. You know, this alcohol is getting sold. All of it, virtually all of it, other than some spillage, for example, should be consumed. So you take some off for spillage and you add a little bit for on recorded alcohol. Not everything is sold from the store. People make their own and so forth. So this is the, basically it's because people are very poor at estimating how much they drink. You know, so we need something more official to kind of hinge that. And then but we still use what they say to build the distribution of how much people drink, and we uplift it to match sales or almost match sales based on spillage and so on. The second piece, Maristella.
I think you answer both. And the other question is, we need to finish. So if you estimated the fetal alcohol spectrum disorders or fetal alcohol syndrome and the studies analyzing pregnant women, how can you study that impact?
That's a great question. That's a very challenging area. That's not an area that I have worked in personally. I know there's work being done at Canada's Centre for Addiction and Mental Health on that. Also work elsewhere. So that's a challenging piece. Tim, do you know any more about that?
I would only say that it's important to emphasize Intermap is quite conservative. So as time goes by, when we have diagnostic information that's routinely recorded and we've got a demonstrated causal, we know, look, in FASD, we know there's causal associations, of course. It's just having reliable data from all regions that we can trust about the extent of the diagnosis. I think it's an area where you need special studies, and they exist. And there's cost estimates for FASD and estimates of the total harm, but we haven't routinely included those. They're on a list of things that, you know, we feel we can't quite tackle. We've got many big ones in Intermap, but that's one we feel the science isn't quite there to be able to do it reliably and accurately.
And I'll just add, because I remembered the other piece of your question, it was about relative risk functions and their applicability to certain regions.
Yes,
So
that's
right. The question asker is right. These are crucial to the estimates that we get out on the other end. The relative risk functions are in almost all cases built from composites of international studies. So they're not region specific. So the functions, the relative risk functions, are not tailored to individual regions. In some cases, the WHO does do that for some specific countries. And that is a good thing to do when possible. But these relative risk functions are, there's not enough studies, individual studies, to build country-specific relative risk functions yet, you know. So maybe in a country, like large countries where there's lots of research, like the US, for example, that could be possible. I think that's something that is conceivable that will happen in the next 10, 20 years, but isn't happening yet.
Yes, I agree. Well, thank you very much to both of you. Thank you for the audience and interpreters and the support, and Jackie, Isabel. And I hope to see requests to use the Intermap so we can all learn more of what is really happening at country level and improve the data to inform policy in the region. Thank you very much. The presentations and the recordings will be available soon, and we'll distribute that via our network. Thanks and goodbye.